The night 6 military helicopters dropped from a blizzard sky onto Cascade Ridge Medical Center, every senior surgeon in the building went pale. 41 soldiers, catastrophic injuries, 5 trauma bays overwhelmed in under 4 minutes. And the only person moving with any real purpose, the only person whose hands weren't shaking, was a 32-year-old ER nurse named Lena Marsh. Not a surgeon, not an attending, a nurse. The woman that Dr. Marcus Holt had spent 2 years talking over, dismissing, and forgetting the name of. She walked into Trauma Bay 3, looked at the dying man on the table, and said 4 words. Everyone step back, now. Before we go further, if stories like this hit different for you, hit that subscribe button and follow along so you never miss what's coming next. These are the kinds of stories that don't get told enough, and I want to make sure you're here for every one of them. Drop a like and tell me in the comments, what city or country are you watching from? I want to see how far this story travels. Now let's get into it. The storm had been building since noon. By the time the first weather alert pinged across the staff phones at Cascade Ridge Medical Center, the nurses on the evening shift had already started pulling extra blankets from the supply closet and checking the backup generator logs out of habit. Cascade Ridge sat at the eastern edge of Harmon County in a stretch of northern Montana where winters didn't arrive so much as detonate, and the staff had lived through enough January nights to know that when the barometric pressure dropped that fast, something was going to break. What broke that night was not a water main or a power line. What broke was a 17-vehicle military convoy on Interstate 46, 11 miles outside of town. Lena Marsh heard about it the way she heard about most things on the overnight shift. Not from her charge nurse, not from administration, but from the paramedic radio traffic crackling through the portable unit that Barry Solis, the overnight EMT coordinator, kept propped on the corner of the nurse's station desk. She had been charting a post-op patient's vitals for the last 20 minutes, her handwriting tight and unhurried in the margin of the paper form because the electronic system had been cycling through a software update since 8 o'clock, and nobody from IT had responded to the ticket yet. Multiple vehicles, confirmed rollover on the 46 northbound, military transport, were looking at least 30, possibly more, requesting trauma center status. Lena set her pen down. She looked at Barry. He was already on his feet. She looked at the clock. 11:47 p.m. She looked back at her chart, wrote one final number, oxygen saturation 96% stable, capped the pen, and stood up. There was no dramatic breath. No visible shift in her posture. She simply stopped doing one thing and started doing another, the way someone changes lanes on an empty highway. Smooth, deliberate, without any particular announcement. She walked to the supply corridor and began pulling trauma kits before the overhead page had even finished crackling through the intercom. All available trauma staff to the emergency department. All available trauma staff to the emergency department. This is not a drill. The sound of running feet followed almost immediately. Then voices, overlapping, urgent. Then the distant thud of the first helicopter finding the rooftop pad, its rotors hammering against the wind so hard the fluorescent lights in the corridor seemed to shiver. Lena counted the kits, counted the blood bags in the mobile cooler, counted the available trauma bays, 5 active, 1 down for maintenance since Tuesday, and made 3 separate mental calculations in roughly the time it took the overhead page to repeat itself. She had done this before. Not here, not in this building, not in this county, not in any hospital with a gift shop on the ground floor and a patient satisfaction survey taped to every discharge clipboard. But she had done this before, and the arithmetic of mass casualty events had a particular logic that did not change with geography. You sorted by survivability. You moved the salvageable ones first. You did not flinch. She had learned that in a different life, in a different uniform, and she had spent the last 4 years trying to forget most of it. But the body remembered. Dr. Marcus Holt arrived in the emergency department at 11:53, his surgical cap already tied, his expression carrying the particular brand of controlled alarm that senior surgeons cultivated the way other men cultivated golf swings. Practiced, performative, designed to communicate authority even in crisis. He was 47 years old, chief of trauma surgery at Cascade Ridge for the past 6 years, and he had a habit of walking into rooms and immediately assessing who in the room was worth talking to. It was not a conscious habit. It was simply how he had been trained, and the training had calcified over 2 decades into something that felt, to him, like clinical instincts and felt, to most of the nursing staff, like being looked through rather than looked at. He scanned the department. He saw residents clustering around the bay doors. He saw the charge nurse, Donna Peach, on the phone with radiology. He saw the anesthesiology attending pulling a cart. He saw Dr. Yael Ostrowski, his second-year surgical fellow, heading toward Trauma 2 with a face the color of old paper. He did not, in that initial scan, register Lena Marsh at all. She was at the supply cabinet. She was a nurse. His brain filed her in the background category without conscious decision, the way a driver registers a familiar road sign. Present, noted, irrelevant to immediate navigation. He moved toward Donna. How many incoming? 41 confirmed. Medevac is staging in waves. First 6 already upstairs, ETA to trauma bays under 3 minutes. Surgical backup? Dr. Parveen is 40 minutes out, roads are closed past the highway junction. Dr. Allard called in earlier. He's snowed in at his cabin. We have you, Ostrowski, and the 3 second years. Holt processed this. Lab? On standby. Blood bank is pulling ONEG now. Imaging? 1 CT operational. The second one has been down since... Fine. He turned. Where's respiratory? What happened in the next 90 seconds was the organized version of panic, which is to say, it looked like competence from the outside and felt like controlled drowning from the inside. Staff moved. Equipment rolled. The bay doors opened and the first wave of patients came in on stretchers, 4 of them in under 2 minutes, and the controlled environment of the trauma department began its rapid conversion into something louder and more honest. Lena was already at Bay 3 when the stretcher arrived. The paramedic pushing it was young, maybe 25, and his voice had the tight, clipped cadence of someone relaying information they'd memorized because they were afraid if they stopped reciting it, they'd start screaming instead. Male, mid-30s, penetrating chest trauma, tension pneumothorax suspected, BP 60 over palp, SATs dropping, GCS 11 on scene, 7 now. Dr. Ostrowski was supposed to be covering Bay 3. He was not in Bay 3. He was in Bay 2, where a patient had gone into cardiac arrest 30 seconds after arrival, and the second-year resident covering 3, a young woman named Dr. Ferris, 7 months out of medical school, was standing at the foot of the stretcher with her hands slightly raised, the way people stand when they're about to do something they're not sure they remember how to do. Lena looked at the patient. She looked at Dr. Ferris. She looked at the monitor reading, oxygen saturation 63% and falling. And she made a decision that had nothing to do with job titles or institutional hierarchy and everything to do with the fact that the man on the table had maybe 4 minutes of functional consciousness left and probably less. Dr. Ferris. Her voice was quiet, not loud, not sharp, just clear, the way a line on a map is clear. Needle decompression, second intercostal, midclavicular line right side. You have everything you need on that tray. Do it now. Ferris looked at her. She stopped. Started again. I know the procedure, I know you do. Lena had already moved to the patient's right side, positioning. I'm going to be right here. Your hands, your call. Go. Something shifted in Ferris's face. The paralysis broke. She reached for the needle. She did it correctly. She did it fast. The rush of air from the decompression was audible, and the saturation monitor began its slow climb back from the floor. 68, 72, 79. And the patient's color, which had been the particular grayish blue that Lena associated with a very specific and very narrow window of intervention, began its cautious return towards something living. Ferris exhaled. Okay, that worked. It did. Lena was already checking the chest tube tray. Now we're going to need a thoracostomy to keep it working. Walk me through your landmarks. She was not performing the procedure. She was not taking over. She was standing exactly beside Ferris, asking her questions, positioning equipment, maintaining the rhythm of the resuscitation with the particular calm of someone who had managed mass casualty stabilization in places with no electricity and no backup and no possible second chance, and who had learned in those places that the worst thing a more experienced person could do in a crisis was shove the less experienced person out of the way. She had learned that lesson from her own mistakes. She did not think about that now. Bay 1 went critical at 12:14. The patient was a staff sergeant, early 40s, with internal abdominal bleeding that had been missed on the initial field assessment because the external injuries, a broken arm, a lacerated forehead, had been more visible and less lethal. The attending who should have been in Bay 1 was Dr. Holt himself, but Holt had been pulled into the OR upstairs at 12:08 with the most complex case, a soldier with a traumatic aortic injury, and Bay 1 had been handed to a second-year resident named Travers, who was technically qualified to hold the room and practically was not ready for what walked through the door. Travers recognized the bleeding at 12:14. He ordered imaging. He ordered blood. He did the things the textbook said to do. What the textbook did not adequately prepare him for was the moment the patient's pressure crashed to 50 systolic, and the blood he'd ordered hadn't arrived yet, and the imaging showed a splenic laceration that was going to kill the man in the next 20 minutes unless someone opened him up, and he, Travers, did not have the training or the clearance to open anyone up. He called upstairs for Holt. Holt was in a sterile field. He could not leave. Travers called for Ostrowski. Ostrowski was in Bay 4 with a bilateral femur fracture that had nicked the femoral artery. He stood in Bay 1 looking at the crashing patient and the arriving blood and the useless imaging results. And he did what intelligent people do when they are genuinely out of their depth. He walked into the corridor and said, loudly and without pride, "I need help." Lena was passing with a supply cart. She stopped. She looked at him. Then she looked through the bay window at the monitor. Then she looked back to Travers. "What do you have?" she asked. He told her, fast, organized, accurate. She gave him that. He was precise under pressure even when he was scared. Splenic lac, grade 3 at minimum, probable 4, BP declining despite 2 large bore IVs and 2 units of O negative in, estimated blood volume down by 1/3. "He needs the OR," Travers said, "but there's no... He needs the OR in 20 minutes. Lena set the cart aside. She moved to the patient. She ran her hands across his abdomen, not hesitantly, not gently, but with the kind of practiced, purposeful pressure that tells an experienced clinician what imaging only confirms. The rigidity, the location, the guarding response even in a semi-conscious patient. Right now, he needs pressure control while we get him there. Do you have a Rebo-A kit on this floor?" Travers stared at her. "Do you have a Rebo-A kit?" she repeated. Not louder, just more precisely. Yes, it's in the trauma equipment room, but get it." He went. Rebo-A, resuscitative endovascular balloon occlusion of the aorta, was not a nursing procedure. It was not technically something that belonged in the hands of anyone without a specific credential and specific training and specific authorization from a supervising physician. It was a bridge intervention, a stopgap, a way to buy time for a surgical team to arrive when the alternative was a patient dying in a trauma bay while the elevator was busy. Lena had performed it in 3 different countries under conditions that made this trauma bay look like an operating theater. She had performed it without imaging guidance, without proper equipment, using supplies improvised from whatever was in the field kit that day. She had performed it in a sandstorm once, with her headlamp failing, on a soldier whose name she still remembered because she had been holding his hand when he told her his daughter had just learned to walk. She did not perform it now. What she did was this. She positioned the patient, she established the femoral access herself while Travers was still coming back with the kit, and when he returned, she talked him through the balloon placement with a precision and patience that should, by any reasonable measure, have been impossible for someone under that level of pressure. "You're going to feel the resistance at the bifurcation," she said. "Don't force it. Let the wire lead, slow. I've never done this outside of simulation. I know, you're doing it now. Slow." The balloon inflated, the pressure held. The patient's systolic climbed from 48 to 71. Travers looked at the monitor. He looked at his own hands. He looked at Lena. She was already on the phone calling the OR coordinator. "I need a room in 8 minutes," she said. "Splenic lac, grade 4, hemodynamically unstable, bridged with Rebo-A. He will not survive a longer wait. Find me a surgeon." By 1:15 in the morning, 6 separate trauma scenarios had been stabilized across the department. Not resolved, not fixed. Stabilized, which in a mass casualty event is the difference between a crisis and a catastrophe, the narrow margin between the patients who make it to surgery and the ones who don't make it anywhere. Lena had moved through all 6 bays, not as the lead clinician, not formally. She had not declared herself in charge of anything or introduced herself to any patient's family or written a single order in any chart. She had been, officially, support staff, a nurse assisting with equipment, managing supply, keeping the floor organized. But the residents had started following her, not because she told them to, because when she spoke, what she said was right, and when things went wrong, she saw it 3 seconds before anyone else did. And when she moved to correct something, the correction worked. It was not the kind of authority that announces itself. It was the kind that accumulates, incrementally, in the space between one good call and the next, until the people around you stop questioning and start listening and eventually stop being aware they've made a choice at all. Dr. Ferris had asked her, somewhere around 1 o'clock, while they were stabilizing the chest patient for transport, "Where did you train?" Lena had handed her a clamp. "Keep that occlusion steady." Ferris had kept it steady. She hadn't asked again. The question hung in the air of the trauma bay longer than either of them acknowledged. At 1:47, the last incoming patient from the convoy arrived. She was not a soldier. She was a civilian contractor, 38 years old, who had been riding in a support vehicle at the back of the convoy when the lead trucks jackknifed on black ice and the chain reaction compressed 14 vehicles in under 6 seconds. Her name was Alicia Rowe, and she was conscious and furious about it. The kind of furious that people get when they're hurt badly enough to be terrified, but functional enough to talk, which is a particularly useful and exhausting combination in a trauma setting. "I told them the road was wrong," she was saying as the stretcher came through the bay doors. "I said it. I said the 46 northbound had a grade change at mile marker 32, and the trucks were too heavy for the seat." "Ms. Rowe." Lena was beside her immediately. "What hurts?" "Everything hurts. My hip hurts the worst." On a scale, "I don't do scales. My hip is wrong. Something is wrong with my hip." Lena looked at the position of the leg. She looked at the shortening. She looked at the external rotation. She put one hand on the patient's pelvis, gently, not pressing, just finding the landmarks. "You have a hip dislocation," she said. "Possibly a fracture. We need imaging." "I could have told you that." "You did, indirectly." Lena was reaching for the trauma assessment form. "Are you on any blood thinners? Any cardiac medications?" "No, I'm healthy. I'm completely healthy except for whatever your road did to my hip." "It's the state's road. Don't be funny with me right now." "Fair enough." She kept working. "Allergies?" The intake went on, fast, thorough, professional. Alicia Rowe kept talking. About the road, about the convoy, about the fact that she had filed 3 separate safety memos in the last 6 months about the condition of that stretch of highway. And Lena listened to approximately half of it with the part of her brain that wasn't simultaneously calculating the patient's pain level, her vascular status, the timeline to orthopedic intervention, and the current availability of imaging. It was while she was getting Alicia Rowe's IV access established that she became aware someone was standing in the bay doorway. She did not look up immediately. She finished the cannula insertion, secured it, connected the line, checked the flow, and then she looked. Dr. Marcus Holt was standing in the doorway. He was not looking at the patient. He was looking at Lena. His expression was the particular expression of a person who has walked into a room expecting to find one thing and has found something else entirely. Not alarmed, not angry, just temporarily recalibrated, the way you look when you reach for a door handle in the dark and find it's not where you remembered. "Nurse!" He stopped. "What's your name?" She had worked alongside this man for 2 years. "Marsh," she said. "Lena Marsh." He nodded slowly, the way people nod when they're not really nodding at you, but it's something they're processing internally. "The patient in Bay 1, he said. "The REBOA. Dr. Travers performed the intervention. The patient is in OR2 now." "I heard." He stepped further into the bay. "The guidance on the balloon placement, where did that come from?" Lena checked the IV flow one more time. She checked the monitor. She looked at Alicia Rowe's leg position and made a small adjustment to the pillow supporting it. "Travers is a good resident," she said. "He just needed someone to walk him through the steps." "That's not an answer." "No," she agreed. "It's not." She picked up the chart. She wrote one line. She moved toward the bay door. "Marsh?" She stopped. Holt was looking at her the way surgeons look at imaging results that don't match the clinical picture, with the specific attention of someone who has realized the data and the diagnosis are not telling the same story. The patient in Bay 3, the needle decompression. Dr. Ferris performed some, "I know what the chart says." His voice was not loud, not aggressive, just precise. "I also know what Ferris said when I talked to her 5 minutes ago. She said she was going to freeze, and you, a nurse, talked her through that intervention with the kind of guidance she'd expect from a senior attending." He paused. "And the thoracostomy." "Dr. Ferris performed the thoracostomy. Under your direction." The bay was quiet except for Alicia Rowe's breathing and the soft alarm of a monitor in the adjacent room and the distant sound of the storm pressing against the building's east wall. Lena looked at Holt. For 2 years she had existed in his peripheral vision. For 2 years she had been the background noise of his clinical environment, competent, quiet, invisible in the specific way that competence without credentials is invisible in institutional medicine. She had handed him instruments. She had charted his orders. She had, on at least 3 occasions, identified medication errors in his residents' charts before they reached patients, and she had corrected those errors without comment, without credit, without any apparent expectation of either. She had been very careful. She had been careful because she understood what happened when someone looked at you too closely, what they found, what they expected you to explain. "It was a busy night," she said. She walked out of the bay. Holt watched her go. His hands were still at his sides. The expression on his face had shifted, not into suspicion, not quite, but into something slower and more careful than anything she had seen on him before. She did not look back. At the end of the corridor near the fire exit, she stopped. She stood still for exactly 4 seconds. She could feel her own pulse in her hands. Not racing, not elevated, just present, the way it always was when she'd been working in that register for too long. The register she was not supposed to use anymore. The one she had promised herself. In a different city, in a different year, standing outside a chapel she had refused to enter, that she was done with. She had been so careful. She pressed her back against the wall and looked up at the ceiling and did not close her eyes, because closing your eyes in the aftermath of something was a habit she'd broken a long time ago, and she wasn't going to relearn it now. Down the corridor, she could hear Holt's voice. He was talking to someone. One of the residents, maybe, or Donna Peach, she couldn't tell. His voice had a different quality than it had 20 minutes ago. Slower, more deliberate. She recognized that quality. It was the voice of a person who had started asking a different question. She pushed off the wall. She had 3 patients to check on and a supply cart to restock, and a shift that still had 4 hours left in it, and whatever question Marcus Holt was starting to form in his head, she was not going to be the one who answered it. Not tonight. Maybe not ever. She walked back toward the nurse's station, pulled her chart clipboard from the rack, and began writing. Her handwriting was as steady as it always was. Her hands did not shake. That was the thing about having done something long enough and hard enough in conditions that made everything else look manageable by comparison. The hands stopped shaking. The voice stopped catching. The body found its own level and held it, regardless of what the mind was doing underneath. She wrote the time. She wrote the vitals. She wrote the interventions. She did not write her own name anywhere except where the form required it. At 2:23 a.m., as the storm outside began its slow, grudging retreat from the county and the last of the convoy patients was stabilized and the trauma department began its transition from emergency surge to exhausted maintenance, Dr. Marcus Holt pulled up the nursing personnel records on the department computer. He found Lena Marsh's file. He opened it. He read for 90 seconds. Then he sat back in his chair, and his face went through 3 distinct expressions in rapid succession, and the third one, the one that settled, was not the controlled authority of a chief surgeon managing a crisis. It was something considerably more complicated than that. He reached for the phone. He stopped. He looked at the file again, at the employment history section, at the 4-year gap before Cascade Ridge, at the line that said simply, prior experience, federal/institutional, details upon request. He looked at the trauma bay records from the last 3 hours, the timestamps, the patient outcomes, the clinical decisions that the documentation attributed to residents who had, in every case he could now trace, been guided by a single consistent presence. He put the phone down. He picked up his coffee, which was cold, and he drank half of it anyway. Down the hall, he could hear Lena Marsh's voice, calm, unhurried, reading back vitals to a patient who was asking where he was. Cascade Ridge Medical Center, she said, Harmon County, Montana. You're safe. You're going to be okay. The patient said something Holt couldn't make out. I know, she said. I know. Just rest. Holt sat in the dim light of the nurse's station and looked at the file and looked at the empty hallway and thought about 2 years of mornings in which he had walked past this woman without seeing her. And he thought about the Reboe balloon and the needle decompression and the 6 patients who were currently alive in this building, who, by any reasonable clinical assessment, should not have been. He thought about the line in her file. Prior experience. Federal/institutional. Details upon request. He reached for the phone again. This time, he dialed. The call connected on the 3rd ring. Personnel records. This is Quan. This is Dr. Marcus Holt, Chief of Trauma Surgery at Cascade Ridge Medical Center, Harmon County. I need to run an employment verification on a current staff member. The file has a federal hold on the prior experience section. A pause. The sound of typing. Name? Marsh, Lena Marsh. Current nursing license, Montana Board. She's been on my staff for... Hold, please. The hold music was instrumental and deeply inappropriate for 2:30 in the morning after a mass casualty event. Holt sat with the phone pressed to his ear and looked at the hallway and listened to it and waited. The typing on the other end resumed. Stopped. Resumed again, faster this time. Then a different voice came on the line. Male, older, flat in the particular way of people whose professional lives required them to be flat. Dr. Holt, who authorized this inquiry? I'm the chief of surgery. I'm authorizing it. That's not what I asked. Holt straightened slightly in his chair. I have a nurse on my floor whose clinical performance tonight was significantly beyond her documented scope. I have a federal hold on her prior employment record. I am asking for clarification on what that hold covers and who I need to contact to The hold is active and in good standing, Dr. Holt. I can confirm Ms. Marsh is currently employed in the capacity listed in your facility's records. Beyond that, this line cannot help you. Can you tell me who can? Another pause. Longer. Someone will be in contact, the voice said. The call ended. Holt looked at his phone. He looked at the dead screen. He set it face down on the desk, which was a thing he almost never did. And he sat for a moment in the quiet of the nurse's station, thinking about what someone will be in contact meant at 2:34 in the morning when the person you'd just asked about was 40 feet away, reading back a patient's medication list. He did not sleep that night. Neither did Lena. She knew he had made a call. She didn't know to whom, but she recognized the sequence. The way Holt had gone quiet after the personnel computer. The specific quality of his silence when he walked past the nurse's station at 2:40 and did not speak to her, which was different from his ordinary silence in her direction. His ordinary silence was the silence of someone who did not think about her at all. This one was the silence of someone who was thinking about nothing else. She had 4 years of practice at identifying that particular distinction. She finished her shift. She charted every patient interaction with the same flat accuracy she always used. Precise, clinical, attributed correctly. Every procedure to the resident who performed it. Every decision framed as support and assistance. She was very good at writing charts that were technically true and deliberately incomplete, which was a skill she had developed not out of dishonesty, but out of the particular self-preservation instinct of someone who understood exactly what happened when institutions decided you were more interesting than you wanted to be. At 6:15, when the day shift began arriving in coats still damp from the parking lot, Lena gave her hand off to the oncoming nurse, a steady, older woman named Gloria Tesh, and gathered her bag and her thermos and walked to the elevator. She did not look at Holt's office as she passed it. She did not need to. The light was on. She could see it in her peripheral vision, the strip of yellow under the door, the shadow of movement, the fact that he was in there at 6:15 in the morning after a night like that instead of in his car. She pushed the elevator button. She rode down to the parking structure. She sat in her car for 6 minutes without starting it. Outside, the storm had finally emptied itself out, leaving everything clean and very white and very still. The kind of morning that arrives after a bad night, the way silence arrives after a long argument. Not peaceful, exactly, but exhausted. The parking structure was half empty. The overhead lights hummed. A sparrow had gotten in somehow and was moving along the ceiling beam with the unconcerned focus of something that did not understand it was in the wrong place. Lena started the car. She drove home. She did not call anyone. There was no one, particularly, to call. The meeting request hit her phone at 9:47 a.m., 4 hours after she'd gotten home, 40 minutes after she'd stopped trying to sleep. Dr. Holt's office, 2 p.m. Please confirm attendance. Donna Peach, charge nursing. She looked at it for a while. Then she confirmed. She spent the morning doing the things that occupied her on days off. Laundry, a grocery run in which she spent 14 minutes standing in the cereal aisle without selecting anything because she was running calculations in the back of her head that had nothing to do with breakfast. A walk in the park at the edge of her neighborhood where the snow was undisturbed except for bird tracks and the long shadows of bare trees. She liked the park in winter specifically because it was quiet and because quietness had taken her a long time to learn to tolerate, and she considered it a form of maintenance like stretching. She had been a person for whom quiet used to feel like a threat. She was working on that. At 1:45, she drove back to the hospital, changed into her badge and her coat, and knocked on Holt's office door at precisely 2 o'clock. "Come in." He looked like a man who had not slept, which was accurate. He was in a fresh surgical shirt, but his eyes had the flat, slightly scorched quality of extended wakefulness, and there was a coffee cup on his desk with the distinct ring stain of being refilled multiple times. His desk also had, she noticed immediately, a printed document face down beside the keyboard. She sat in the chair across from him. He looked at her for a moment without speaking, which she let him do. She had learned early that people who needed to speak first should be allowed to find their way there. "I made a call last night," he said, "after I pulled your personnel file. I assumed you would." That stopped him. "You assumed. You had enough questions by 1 a.m., and you're not someone who lets questions sit. It wasn't a criticism." He picked up his coffee, put it down without drinking it. "The call got transferred to someone who told me a hold was active and that someone would be in contact. I don't know what that means." "It means the hold is active," she said. "Lena." He leaned forward. 6 patients. I went through every Bay record this morning. 6 patients who, without the interventions that happened last night, would have had outcomes ranging from severe neurological compromise to death. The documentation says residents performed those interventions. The residents themselves, when I spoke to them this morning, told me a different story. She said nothing. "Travers told me you talked him through a Reboe placement in real time. Not read it to him out of a manual, walked him through it like you'd done it 100 times. He paused. "Had you done it 100 times? The office was quiet. Down the hall, someone was laughing at something. A brief, bright sound that vanished almost immediately. "The REBOA was Dr. Travers's intervention," she said. "I assisted." "Stop doing that." "Doing what?" "Saying the accurate version instead of the true one." His voice didn't rise. He just made the words more precise, the way you tighten a focus. "Who are you?" It was the same question he'd asked last night in the trauma bay, and she'd walked away from it then. She couldn't walk away from it here. She was in a chair in an office with the door closed and her employment file face down on the desk, and the man across from her had the expression of someone who would sit here as long as it took. She looked at him. She thought about the soldiers, about the ones she'd saved and the ones she hadn't, and the particular arithmetic of that, and the long sequence of decisions that had led from a forward operating base in a country that no longer appeared prominently in the news to a chair in a trauma surgery chief's office in northern Montana. "What I tell you," she said, "stays in this room." That depends on what it is. No, she said. It doesn't. That's the condition. Another silence. He considered her. All right, he said. She told him. Months. Not everything. She was careful about what she gave him, the way you're careful about structural weight. You put enough on the frame to demonstrate it can hold, and you stop before you test whether it can't. She told him she had been Army. Medical Corps. Attached to a unit she described only as specialized evacuation, which was a description that left out most of the specifics and contained just enough to let him understand the shape of what she meant. She told him she had surgical training that predated her nursing license, formal training, credentialed, earned in circumstances that made hospital residencies look like controlled environments, which they were. She told him she had left the military 4 years ago after an operation that had gone wrong in the specific and permanent way that some things go wrong, and that she had chosen nursing afterward because nursing let her do the work without the weight that came with the rank she no longer wanted. She told him the federal hold was there because some of what she'd done was classified, and some of it was operationally sensitive, and the hold wasn't punitive. It was protective, but the effect was the same. Her file looked like a gap, and the gap made administrators nervous, and she had found over 4 years that it was easier to let people be nervous at a manageable distance than to explain the truth at a distance that no longer felt manageable. When she finished, Holt was quiet for a long time. "Why nursing?" he asked. Not skeptically, just asking. "Because nurses keep people alive," she said, "and nobody gives them a command structure." He looked at the face-down document. Then he reached over and turned it face up and slid it across the desk toward her. It was the trauma department's outcome report from the previous night. She scanned it. 6 critical patients, 6 survivals. Discharge trajectories ranging from intensive care to general ward. Prognosis notes that used words like remarkable and unexpected, and in one case, outcome inconsistent with initial presentation severity. "I need to know," he said, "whether what happened last night was a one-time thing or whether—" "It wasn't one time," she said. "Then I need to think about what that means for your role here." "Don't," she said. He frowned. "Don't think about it?" "Don't change my role." She slid the report back across the desk. "I know what you're thinking. You're thinking about what that looks like, what it means for liability, for scope, for the institutional conversation you'd have to have about a nurse who operates at an attending level without attending credentials in your system. You're thinking about what Harmon County Medical Administration does with that information." She looked at him steadily. "And I'm telling you that the reason last night worked was because nobody was watching it happen. The moment you formalize it, it stops working. That's how institutions work." He sat back. He did not agree immediately, which she respected. He actually thought about it, which she respected more. "You can't just stay invisible forever," he said finally. "I've managed 4 years. Last night changed that. Only if you let it." He picked up the coffee. This time he drank it. He grimaced. It was clearly long past good, and set it down and looked at her with an expression that was not the processed, performative authority she'd observed in him for 2 years. It was something more tired and more honest than that. "I owe you an apology," he said. She had not expected that. "For last night?" she said. "For 2 years." He didn't look away from her. "I don't know your name." "I didn't know your name until I pulled the file. You've been on my floor for 2 years and I didn't know your name, and I've watched myself not know it, and I've called it a personality type and a professional style, and it isn't either of those things. It's just—" He stopped, started again. "It's a way of looking at people that I've had long enough that I stopped seeing it as a way of looking. I just thought I was seeing clearly." The office was very quiet. "Okay," she said. "That's it? What do you want me to say?" He almost smiled. It didn't quite make it all the way to his face, but she saw the edges of it. "Nothing, probably," he said. She stood. "I have patients to check on. Lena." He didn't stand, but his voice had a different quality now. Not the questioning precision of the last hour, but something more careful. "Whatever the hold covers, whatever happened in the operation you mentioned, I'm not going to push." She nodded once. "But I'm going to think about what you said, about the role." "Think about it quietly," she said. She left his office. What she didn't know, and what Holt did not tell her because he did not yet know it himself, was that his call at 2:30 in the morning had not stopped at the personnel records line. It had traveled considerably further. The person who had told him someone will be in contact had, after ending the call with Holt, made 3 calls of their own in rapid succession, 2 to numbers that did not appear in any public directory, and 1 to a man named Deputy Director Warren Stroud of a Federal Medical Oversight Division whose operational remit was specific enough and classified enough that most people in federal medicine had never heard of it, and the people who had heard of it did not discuss it in places with network access. Stroud had been awake. Stroud and Lena's experience, and it was an experience she'd had in a different context, years ago, in a way that had left specific residue, was almost always awake. He listened to the summary, the mass casualty event, the convoy, the clinical interventions, the personnel inquiry from a trauma chief in Montana. "Marsh," he said. "Yes, sir." "How long has she been at Cascade Ridge?" 4 years, sir, under the relocation parameters." "Anyone else make inquiries?" "Not through official channels. One call, Dr. Holt. The description I got was thorough. He seemed very thorough." Stroud had been quiet for a moment, then, "Send me the outcome report from the trauma event, all of it." "Sir, those are civilian hospital records. We'd need a—" "Send me the outcome report." The call had ended, and Stroud had sat in his office in a building that didn't have a public address and looked at the window for a while, because he had known, when they'd set up the parameters 4 years ago, that the parameters had an expiration point. They always did. The people who needed them most were invariably the ones least able to stay inside them for long, not because they were careless, but because they were exactly what they were, and what they were didn't switch off, and in the right circumstances always eventually came. The circumstances had come. The question was what to do about them. 3 days passed. The convoy patients stabilized and began their slow migrations through the hospital, from ICU to step down, from step down to general ward, from general ward toward discharge. The staff sergeant from Bay 1, whose name was Dario Fusco, was extubated on day 2 and spent most of day 3 eating applesauce and demanding to know where his boots were. The chest trauma patient from Bay 3, the first one, the needle decompression, the man with the saturation of 63%, was moved out of the ICU on day 3 and asked the nurse who came to check his vitals whether the person who'd been in the room when he came in was still working in the building. The nurse, Gloria Tesh, who had heard the stories by then in the particular way that hospital staff hear things, which is comprehensively and imperfectly, said she thought so. "I want to thank her," the patient said. "I'll pass it along." She did pass it along. She told Lena directly, leaning against the nurse's station counter in the particular offhand way she had of delivering information she knew was significant. Lena said, "I'll go by when I get a chance," and charted 3 more vitals, and Gloria watched her for a moment and then went back to her own work. The hospital, meanwhile, had noticed something, not officially, not in any documented or proceduralized way. But hospitals are small communities in the way that small towns are small communities. The information that moves fastest is the information that can't be put in a memo. And the information that can't be put in a memo in this case was a growing, informal, shift-to-shift awareness among the nursing staff and the junior residents that the patient in Bay 1 who shouldn't have survived had survived, and the patient in Bay 3 likewise, and that the common variable in 6 survival scenarios across one catastrophic night was a 32-year-old nurse in standard-issue scrubs who'd been working on this floor for 4 years without anyone asking her very many questions. The residents had started asking questions, not of administration, not formally. They asked at the nurses' station, at shift change, in the break room over bad coffee at odd hours. Careful, oblique questions that were mostly not questions but observations phrased upward. She told me to adjust the landmark, and she was right. She caught the pressure drop before the monitor alarmed. I've never seen anyone move that fast and be that quiet about it at the same time. Dr. Ferris had come back to the floor on day 2 and found Lena restocking the crash cart and had stood beside her and restocked alongside her in silence for 3 minutes before saying quietly, "The thoracostomy patient is going home Thursday." "I know," Lena said. "His drainage numbers look good." He asked who the nurse was. "What did you tell him?" I told him your name. A pause. Was that okay? Lena looked at the crash cart tray. She counted the ET tubes. She adjusted the positioning of the laryngoscope. Yeah, she said. That's fine. Ferris nodded. She picked up the next tray. Where did you actually train? You don't have to... She stopped. You don't have to tell me. I'm not asking because I have a right to know. I'm asking because I want to understand what I'm looking at. It was a more honest question than most people managed, and Lena had a certain amount of respect for honest questions, even when she wasn't going to answer them. You're looking at someone who's been doing this a long time in places that required it, she said. That's enough. Ferris thought about that. Is it classified? Parts of it. Are you going to get in trouble? Because of last night? Lena closed the crash cart drawer. I don't know yet. That was the truest thing she had said in 3 days. The trouble arrived on the morning of day 4 in the form of Richard Calloway, the hospital's executive director of operations, who was 44 years old and had the specific energy of a person who had been hired primarily to prevent other people from making decisions that cost the institution money, and who was very good at his job in the sense that he was relentless and very bad at his job in the sense that he had no clinical instincts whatsoever and found this to be no obstacle to forming confident clinical opinions. He arrived in Donna Peach's office at 8:15 with a printed copy of the preliminary incident review from the convoy event and the particular expression of someone who had identified a problem and was very clear on the solution. The nursing staff exceeded scope, he said, before Donna had fully closed the door. Specifically, Nurse Marsh. Donna sat down. She folded her hands on the desk. She had been charge nursing at Cascade Ridge for 11 years, and she had dealt with Richard Calloway in some version or another for 6 of them, and she had learned that the fastest way to disagree with him was to do it slowly. The patients are alive, she said. That's not the point. The liability exposure here is, Richard, 6 people who should have died are in this building recovering. That's the point. The point, he said, and his voice had the clipped certainty of someone who had prepared this particular argument before the meeting, is that a nursing staff member performed procedures outside her credentialed scope during an emergency event, and now I have 6 patient charts that have to be reviewed for protocol compliance before any of those patients or their families decide to speak to an attorney. Donna looked at him. Are you suggesting we should have let them die? I'm suggesting the hospital's position needs to be... Richard, she leaned forward. If you're about to tell me to take action against a staff member because she kept 6 military personnel alive during a mass casualty event, I'm going to ask you to put that in writing, and I'm going to tell you exactly where that writing ends up. He stared at her. The preliminary review goes to Dr. Holt's desk for clinical sign-off, she said, like every incident review. If Dr. Holt clears it, it clears. If he has concerns, those go through the standard process. You don't get to skip that step because you're worried about optics. Calloway left. He was not done. She knew that the way she knew weather as a reliable pattern. But he left, and Donna sat in her chair for a moment and then called Marcus Holt's extension. He picked up on the second ring. Calloway just came to my office, she said. He's building a case. I know. A pause. He came to mine yesterday. I sent him to get the full clinical record first. Did that slow him down? For about 18 hours. Another pause. Donna, how solid is Marsh's documentation? Donna thought about this honestly. It's clean. Everything's attributed correctly. The residents performed the interventions on record. But anyone who reads it carefully and knows what to look for is going to see the fingerprints, the sequencing, the fact that every critical decision across 6 bays in one night followed the same pattern. Yeah. His voice was tired in a way that wasn't physical. That's what I thought. She closed her eyes briefly. What are you going to do? I'm going to sign off on the preliminary review, he said, and then I'm going to make a phone call. A different one than the one I made 3 nights ago. 2? I don't know yet, but I have a name. After she hung up, Donna sat very still in her office for a moment, looking at the window where the last of the storm's snow was sliding from the windowsill in thick, wet sheets, revealing the gray sky underneath. She thought about Lena Marsh, about the 2 years she'd watched her work, the quiet competence, the non-negotiable steadiness, the way she positioned herself at the edge of every difficult moment without ever stepping fully into it. She'd thought it was caution. She'd thought it was the particular reserve of someone who didn't like attention. She hadn't thought to ask why. She was thinking about it now, Shaun. Lena was in the supply corridor when her phone vibrated. Not the hospital system. Her personal phone, which was a different device for specific reasons, and which vibrated with the number she had specifically set to a distinct pattern so she would recognize it without looking. She looked anyway. The number was blocked, but the text was not a number. It was 3 letters. ETA 6 hours. She stood in the supply corridor holding her phone and reading those 3 letters and understanding exactly what they meant, and for the first time in 4 days. For the first time since she'd walked out of Holt's office, she felt the thing she had been holding at careful arm's length move closer. She put her phone in her pocket. She picked up the supply tray. She walked back to the floor. 6 hours. She had 6 hours to decide how much she was going to try to control what happened next, and she already knew, in the particular, honest part of herself, that she had worked hard to keep honest even when honesty was inconvenient, that the answer was not much, and possibly nothing at all. What was coming had been coming for 4 years. She had known that. She'd just been very disciplined about not looking at it directly. Down the corridor, she could see Calloway in conversation with someone from administration, and she could see the way he gestured, sharp, clipped, the movements of someone building momentum. And she could see from the angle of the conversation and the direction of his occasional glance that she was the subject of it. She kept walking. She set the supply tray down at the nurse's station and checked the board and read off the patients who needed attention, and she began her work with the same steady hands and the same quiet voice and the same careful competence that had kept her visible enough to be useful and invisible enough to be safe. For 4 years. She had 6 hours left of it. The 6th hour passed without the thing she was waiting for. Then the 7th. Then, at the beginning of the 8th, the elevator opened at the end of the main corridor and 2 people stepped out who did not look like anyone who worked at Cascade Ridge Medical Center, and Lena knew, from the way they moved, unhurried but purposeful, scanning the space without appearing to scan it, that the text had been off by 2 hours and that her time was up. She did not move toward them. She did not move away. She finished writing the medication note she was in the middle of, and capped her pen and set the chart in the rack and turned to face the corridor the way you face something you've been expecting long enough that the expectation itself has become its own kind of preparation. The man in front was tall, 50s, in a charcoal jacket that fit too well to be civilian issue, and not well enough to be tailored, which put it in that specific middle category that federal personnel used when they wanted to look civilian without quite committing to it. He had gray at the temples and a face that had spent a significant amount of time in weather, and a way of holding his shoulders that Lena recognized as the posture of someone who had once been required to hold very still for very long periods in very specific conditions. The woman with him was younger, late 30s, dark hair, carrying a tablet in the way people carry tablets when the tablet is not actually what they came for. They saw Lena at the same time she saw them. The man's expression did not change, which was its own kind of change. "Marsh," he said. Not a question. "Stroud," she said. Not quite a greeting. Warren Stroud stopped at the nurse's station counter. He looked at the floor. He looked at the unit. He looked at the patient board with the kind of assessment that was reflexive and total and took approximately 4 seconds. "You've been busy," he said. "It was a busy night." "More than the one night by the look of it." He glanced at the woman beside him. "This is Agent Callister. She's been coordinating the convoy investigation." Lena looked at Callister. Callister looked at her with the measured professional courtesy of someone who had been thoroughly briefed and was reserving visible judgment. "Is there somewhere we can talk?" Stroud asked. She took them to the family consultation room at the end of the east wing, which was small and had chairs that were designed for distressed people, and a box of tissues on the table that was always half empty, and a window that faced the parking structure. She did not offer them anything to drink. She sat across from them and folded her hands on the table and waited. Stroud did not sit immediately. He stood at the window for a moment, looking out at the parking structure, the way he always had a habit of looking at exit points when he entered a room, and then he sat and put his hands flat on the table and looked at her. The convoy, he said. Tell me what you saw. I saw it in the trauma bay. I didn't see the accident. I know that. I'm asking about the patients. What did you assess? She told him. Clinically, sequentially, the way she had learned to brief, facts first, inferences clearly labeled as inferences, gaps in information explicitly noted. The injuries had been consistent with high-speed vehicle compression trauma. Penetrating injuries from equipment displacement, the pattern had been consistent with a catastrophic deceleration event, not an IED, not a directed strike. Physics, not tactics. Stroud listened without interrupting. Callister was taking notes on the tablet. One of the patients, Stroud said when she finished, Staff Sergeant Dario Fusco, has been requesting to speak with the personnel responsible for his treatment. I heard. He specifically asked for you by name. He was barely conscious when I saw him. People in extremis remember things with surprising specificity, Stroud said. It was not a rebuke. It was just accurate. He told the MPS who came to interview him that a nurse talked him through a procedure and that her voice was... He glanced at the tablet Callister tilted toward him. The same as the voice you hear on the radio when things are going bad, and someone is telling you it's going to be okay, and you know they've been there. He looked up. His words. The room was quiet. He couldn't know that, Lena said. He's right, though. She looked at the window, at the parking structure, at the particular gray light of a Montana winter morning that was exactly the same color as the light had been on the last morning she'd been in country, which was a coincidence of atmospheric optics and nothing more. And she was aware of making a deliberate choice not to follow that particular line of thought anywhere. Why are you here, Warren? She said, not hostile, just tired of the approach. Stroud was quiet for a moment. Then, because Calloway filed a formal complaint with the state medical board this morning. Scope of practice violation, specifically naming you. She had expected this. She had expected it since the supply corridor, since the 3 letters on her phone, since the moment she'd watched Calloway gesturing in the hallway. Expecting something did not prevent the particular weight of it from landing. When? She asked. This morning, 8:42. He paused. He also sent a preliminary memo to hospital legal recommending termination pending review. That's fast. He's motivated. Stroud leaned back slightly. The complaint is going to trigger an investigation. State medical board, hospital compliance, possibly federal, if the patient's military status pulls the department in. Your name is going to be the center of a document trail that a hold cannot contain once the investigation formally opens. Lena looked at him steadily. So the hold breaks. The hold changes. What it covers changes. He was precise about the distinction. The classified operational elements stay sealed, but the framework, the credentials, the service record, the surgical training, that's going to have to surface to defend you against the complaint. She understood what he was saying. She understood all of it, including the part underneath it. Or, she said, he didn't answer, which was its own answer. Or I resign before the investigation formalizes, she said. The complaint doesn't have a target. The board doesn't open a file. The hold stays intact. That option is available, he said. Carefully. Not recommending it. Not recommending it. And the patients? The 6 charts that are going to show scope violations if someone looks at them correctly? Callister's team is in a position to facilitate a review of those charts through federal channels. Given the military status of the patients, there's a jurisdictional argument for each... Warren, she stopped him. Are you telling me you can make the problem go away if I leave? He met her eyes. I'm telling you it's one of the available options. She sat with that for a moment. Outside, a car pulled into the parking structure, and its headlight swept briefly across the window and vanished. What's the other option? She asked. The other option is we let the investigation open, and we respond to it, fully, which means the service record comes out, the surgical credentials come out, the operational training comes out, in whatever form the classification review allows. And you stand in front of the board and defend every action you took that night on its clinical merits. And the classified elements? We manage those. It's complicated, but it's manageable. How long? Weeks, possibly months, during which you're on administrative leave, your nursing license is under review, and Calloway gets to control the public framing for however long it takes. She thought about the patients, about Travers and Ferris and the other residents who would be called to testify, whose own licenses would be examined for their involvement in that night, about 6 charts and 6 people who were alive, and the particular institutional machinery that was now pointed at the fact of their aliveness. "There's a third option," she said. Stroud looked at her. "Let the investigation open," she said. "Don't manage the framing. Put the full record in front of the board and let it stand on what it is." Callister looked up from the tablet. Stroud's expression was not alarmed. It was the expression of a man who had anticipated this and was not surprised, but was measuring it carefully. "That's the same as option 2, he said, "except you're removing the protective framework." "I'm removing the managed framework. There's a difference." She looked at him. "I'm done letting the gap in my file do the explaining. If this is where it opens clean." A long silence. "Lena sit," he said, and it was the first time he'd used her first name. "The classified elements aren't mine to waive. The review would take time. I'm not sure the investigation timeline allows." "Then move fast," she said. She stood. He watched her. "This isn't what the parameters were designed for," he said quietly. "No," she agreed. "The parameters were designed for me to stay invisible. I stopped being invisible 4 days ago." She picked up her badge from the table where she'd set it. "The patients I treated that night are in this building. Calloway is in this building. The investigation is going to be in this building. I'm not leaving." She walked to the door. "Marsh." Callister's voice, the first time she'd spoken directly. Lena stopped. "The staff sergeant, Fusco. He filed a formal statement with the MPS this morning, independent of the board complaint. He specifically requested that the personnel responsible for his treatment receive recognition for their role in the outcomes." Lena looked at her. "He doesn't know what he's asking for," she said. "He knows exactly what he's asking for," Callister said. "He's been in the Army for 18 years. He knows what a controlled detonation looks like." Lena looked at her for one more moment. Then she opened the door and walked back into the corridor, and the hospital sounds came back, monitors, voices, the distant ping of an elevator. And she stood in them for a moment before she moved, finding her level the way she always found it, the way the body finds its level when it's done this long enough. She had approximately 4 hours before anything formalized. She intended to use them working. Richard Calloway was not, by nature, a patient man, but he was a strategic one, and the distinction mattered in institutional environments where patience was unnecessary so long as timing was precise. He had filed the complaint at 8:42. He had sent the memo to legal at 9:15. He had spoken to the hospital's communications director at 10 o'clock to begin managing the internal narrative. And by 11, he was in a conference room with the hospital's legal counsel and a representative from the liability carrier who had flown in that morning from the regional office with the particular energy of someone whose company stood to lose money if this situation escalated without containment. "The core exposure," Calloway said, "is the documentation. If the charts show a nursing staff member directing clinical procedures outside her scope, the charts," said the legal counsel, a woman named Patricia Vane who had been doing hospital defense work for 20 years and who had the flat, efficient manner of someone who had stopped being surprised by institutional crises approximately 15 years ago, "show residents performing procedures. I've read the preliminary review. The residents have all made informal statements to Dr. Holt, indicating that a nurse provided informal statements," Vane said, "made to a fellow staff member, not under oath, not in a formal proceeding. Those statements, as they currently stand, are not discoverable in the way you seem to think they are. When the investigation, there is no investigation yet," Vane said. "There is a complaint. Those are different things. A complaint triggers a preliminary inquiry. A preliminary inquiry may or may not result in a formal investigation. That process takes time, and that time is not your enemy unless you make it one." She looked at him across the table. "Richard, what is it you actually want here?" He looked at her. "I want the liability exposure addressed." "What does that mean in operational terms?" "It means Nurse Marsh should not be in this building while the complaint is pending. Suspending a staff member without cause while a preliminary complaint is under review is itself a liability exposure, a significantly larger one, in my assessment, than the scope complaint." She leaned forward slightly. "Especially given the patient outcomes. The patient outcomes are not Richard. Her voice didn't change. 6 people are alive in this building who the admitting documentation suggests should not have survived without senior surgical intervention. If you push this in a way that publicly characterizes that outcome as a problem, you will lose. I'm telling you this as your attorney. He sat back. He was not done. She could see it in the set of his shoulders, the particular stillness of someone who has been redirected but not redirected enough. The staffing records, he said. The convoy event. The reason we were running those bays with second-year residents at midnight. Vane looked at him. That's a different conversation, she said. Her voice was the same. The eyes were not. Is it? She closed her folder. You should think carefully about what you're implying. I'm not implying anything. I'm noting that the staffing decisions that led to an understaffed trauma department during a mass casualty event are documented in the operational records, and that those records have my signature on some of them and yours on others, and the chief of surgery's signature on none of them, because Dr. Holt has been requesting additional surgical staffing for 14 months, and those requests have been declined at the administrative level for budgetary reasons. The room was very quiet. The liability representative looked at his hands. Vane looked at Calloway. Are you suggesting, she said carefully, that you intend to make the staffing failures part of the public record in order to— I'm suggesting that if this investigation goes wide, the staffing record goes with it, Calloway said, which is why I would prefer a contained outcome. Marsh resigns or is suspended, the complaint is resolved administratively, the charts are reviewed and closed, and nobody looks at the operational decisions that put us in the position of needing a nurse to step outside her scope in the first place. It was a threat wrapped in a strategy. Vane recognized it as both. You're going to have a problem, she said quietly, if Holt decides to go on record. Holt is a surgeon. He's not interested in institutional politics. He signed off on the preliminary review this morning, she said, and he CC'd the state medical board on the cover letter. Calloway went still. He what? I got the notification 20 minutes ago. She opened her folder again. He submitted the full clinical documentation with his signature as chief of trauma surgery, attesting to the medical appropriateness of every intervention in those 6 cases. His cover letter notes that all procedures were performed within emergency exception protocols and that the outcomes represent a successful institutional response to a mass casualty event. She looked at him. He also attached 14 months of staffing request correspondence. The silence had a different quality now. He attached what? Calloway's voice was flat. His requests for additional surgical staffing, 14 months, all declined. She closed the folder. I think Dr. Holt is, in fact, very interested in institutional politics. He's just been waiting for the right moment. But Holt was in his office when Lena knocked. She did not wait for him to answer. She opened the door and looked at him. And he looked at her, and she read in his face, which was the face of a man who had done something he wasn't entirely sure about and was not sorry, the outline of what had happened. You submitted the charts, she said. I'm the chief of trauma surgery. Submitting clinical documentation is my job. Marcus. He looked at her. It was the first time she had used his first name. He registered it. You attached the staffing records, she said. The staffing failures are relevant to the clinical context. An understaffed trauma department during a mass casualty event is the reason why exceptional measures were necessary. You can't evaluate the interventions without the context. You know what you've done. I've made a record. His voice was steady. An accurate one. She sat in the chair across from him. She put her hands in her lap. She looked at the desk. 2 federal agents are in the building, she said. One of them is my former division supervisor. The complaint Calloway filed this morning is going to trigger a review that may surface elements of my employment history that I have spent 4 years managing carefully. He listened. The review is going to find a service record, she said. Military Medical Corps, attached to a specialized trauma and surgical evacuation unit. Operational deployments across 4 rotations. A field surgical credential that is not equivalent to a civilian attending license, but is, in terms of actual procedural experience, more extensive than most surgical fellowships. She looked at him. And it's going to find the incident, the operation that ended my service. What happened? She had told him the outline. She had not told him the weight of it. "We had a medical officer," she said. "Senior to me. Good surgeon in garrison, in a hospital, in controlled conditions. In the field, he made decisions based on what made sense theoretically, not on what was actually in front of him." She stopped. "We had a casualty. A bad one. Abdominal trauma, internal hemorrhage, the kind that requires immediate intervention, not delayed, not managed, not stabilized for transport. Immediate." She looked at the window. "He ordered transport. The soldier was not transportable. I told him that. The other medics told him that. He ordered transport because that was the protocol." The office was very quiet. "The soldier died en route," she said, "but 12 minutes after we loaded him. He would have survived intervention on site. I know that because I've done that intervention. I've done it in worse conditions with less." "What happened after?" "I filed a formal objection to the medical decision. A full written report with clinical rationale." She looked at Holt. "The officer I filed it against had a relationship with the commanding general. The report was dismissed. The incident was classified. I was reassigned." She stopped. 3 months later, I requested discharge." He said nothing. "The hold on my file," she said, "covers the incident report, the classified elements. It does not change the fact that I left." She looked at her hands. "I left because I was wrong about what I could tolerate, and I didn't know that until I found out I was wrong." "You came here," he said. "Nursing doesn't ask you to make decisions that get people killed." "Neither does surgery, in the way you mean." "No," she said. "In surgery, you make decisions that might get people killed. That's different." She looked at him. "In the field, the decisions you make and the deaths that follow are the same decision. There's no distance." He was quiet for a moment. "The residents," he said. "Travers, Ferris. If this goes to a formal investigation, their charts get scrutinized." "I know." "Their licenses could be at risk." "I know, Marcus." "Then you understand why I submitted the documentation the way I did." He looked at her. "I'm not going to let the people who were doing the best they could that night get thrown under the same vehicle Calloway is trying to throw you under. The documentation stands on its clinical merits. You and I both know that." She looked at him for a long moment. "You're going to make an enemy of him," she said. "I've been making an enemy of him for 14 months of budget requests. This is just the part where he finds out." He leaned forward. "The agents. What do they want?" "Stroud wants to manage the exposure. Give me a clean exit or a managed defense." "And you?" I told him neither. Something shifted in Holt's expression. Not surprise. Something more like recognition. "Good," he said. Her phone vibrated. She looked at it, a text from a number she did not recognize, which meant it was from the network she was not supposed to have access to anymore, and which had apparently decided she still did. 4 words. "Board rep arriving 3 p.m. She looked at the time. It was 2:41. "I have to go," she said. She stood. She moved toward the door. "Lena." His voice stopped her, but not the way it had in the trauma bay 4 days ago. This was different, lower. "What happened to the officer, the one who made the call?" She held the door handle. "He was promoted," she said. She left. The state medical board representative arrived at 3:04 in the person of a compact, serious woman named Dr. Judith Anand, who was 61 years old and had the demeanor of someone who had conducted enough investigations to have lost both naivety and cynicism and arrived at a third position that was simply precise. She had a briefcase and a badge and the preliminary complaint file, and she asked Donna Peach for a quiet room, which Donna provided. And she asked for Dr. Holt, who came, and she asked for Nurse Marsh, who came last. Calloway was not in the room. He was in the corridor outside it, which Lena registered when she walked past him, and which he registered with the expression of someone who expected to be included in something and has just realized he was not going to be. She did not look at him directly. She sat across from Dr. Anand and folded her hands and waited. "I've read the preliminary documentation," Anand said. "Dr. Holt's submission, the outcome reports, the medication administration records, and the complaint is filed." She looked at Lena. I have some specific questions about the Reboe placement in Bay 1. Of course. The documentation attributes the placement to Dr. Travers. Dr. Travers' own statement, provided informally to Dr. Holt and now formally to this inquiry, indicates that you provided real-time guidance throughout the procedure. She looked at her file. Dr. Travers describes the guidance as, quote, equivalent to instruction from a supervising attending. Can you describe your role in that intervention? Lena looked at her. She thought about the version she had been telling for 4 days. The careful version, the attributed version, the version that was accurate in every documented particular and incomplete in every material way. She thought about what she had said to Stroud. I'm done letting the gap in my file do the explaining. I guided Dr. Travers through the placement, she said, verbally, in real time. I had previously established the femoral access myself while he was retrieving the equipment, because the patient's pressure was at 48 systolic, and the time required for him to prepare the site would have been the time available to save the patient's life. She paused. I made that decision, and I made it deliberately. The room was very quiet. Holt was looking at her. Anand was writing. And your basis for that intervention, Anand said, given your nursing license and scope, my basis, Lena said, is 8 years of trauma surgical experience, 4 of which were conducted in forward operating conditions under military medical corps jurisdiction, with a field surgical credential issued by the Department of Defense. She looked at Anand steadily. I am aware that credential is not equivalent to a civilian attending license. I am also aware that the patient in Bay 1 is alive, and that without that intervention he would not have been. Anand looked at her. She was not alarmed. She was, if anything, more precise. Your military record, she said, the hold on the prior employment section. I have authorized a federal review of the classified elements, Lena said. The non-classified portions of my service record are available to this inquiry immediately. I am requesting that they be obtained and included in the preliminary investigation file. Anand looked at Holt, then back at Lena. Ms. Marsh, she said, that authorization, did you... The door opened. Stroud. He had his credentials in his hand before the door was fully open, which meant he had been standing outside it and had heard enough. Dr. Anand, he said. Warren Stroud, Federal Medical Oversight. I apologize for the interruption. He looked at Lena for exactly 1 second. The authorization she mentioned was processed 40 minutes ago. You'll have the non-classified service record within the hour. Anand looked at him. She looked at Lena. She looked at Holt. Then she looked at the door where, through the narrow vertical window, Calloway's silhouette was visible in the corridor, and she made a note in her file that she did not read aloud. I'll need statements from Dr. Travers and Dr. Ferris, she said, and I'll need the full staffing correspondence Dr. Holt attached to his submission. Of course, Holt said. This inquiry, she said to the room, is formally open as of this moment. Ms. Marsh, you remain on active status pending review unless a clinical safety concern is identified, which based on the documentation before me, it has not been. She closed her file. Do not discuss the specifics of this inquiry with any administrative personnel not present in this room. She looked at the door when she said it. She did not look at Calloway's silhouette. She did not need to. The room began to reorganize, Holt pushing back his chair, Stroud checking his phone, Anand stacking her files with the efficient care of someone who would have everything indexed before she left the building. Lena sat still for 1 moment after everyone else had started moving. The inquiry was open. Her record was moving. The thing she had managed at careful arm's length for 4 years was in the room with her, fully present, and she had put it there herself. She was not sure if what she felt was relief or the thing that lives right next to relief and is frequently mistaken for it. She stood. Stroud fell into step beside her as she moved toward the door. The classified operational review, he said quietly. The incident. The formal objection you filed. What about it? It's going to surface. His voice was low. All of it. The report. What you documented. What happened after? I know. The officer you filed against, he said. He's not a colonel anymore. She stopped walking. She looked at Stroud. He was promoted again, Stroud said. 8 months ago. She stood in the corridor outside a family consultation room in a hospital in northern Montana, and she felt the specific internal quality of a thing she had put away carefully being put back in front of her. And it was not the grief she expected, but something colder and more functional than grief. Something that felt, in her chest, like a tactical reassessment. "How high?" she asked. Stroud told her. Outside the window at the end of the corridor, the parking structure was lit against the early dark of a Montana February, and the light was the same flat gray it had been that morning and the morning before, and it showed her nothing except the cars and the concrete and the fact that it was still winter and would be for a while yet. She looked at it. She thought about a soldier who had died in a transport vehicle 12 minutes after he should have been saved, and about the report she had written and the rank of the man she had written it about, and about the distance between then and now that had seemed for 4 years like enough distance, and which had just, in the space of 10 words, collapsed entirely. "Okay," she said. Her voice was steady. Her hands were steady. But the calculation she was running in the back of her mind was no longer about the inquiry, or the charts, or Calloway's complaint, or even her own record. It was about something older and larger than all of it, and it had just become, for the first time in 4 years, something with an active address. The non-classified service record arrived at 4:47 p.m. Stroud had said within the hour, and he had meant it, which told Lena something about how much of this he had already prepared before he walked through the elevator doors that morning. The file came through the secure federal transfer to Dr. Anand's inquiry account, and simultaneously, by arrangement she had not specifically authorized but had not prevented, to Dr. Holt's administrative login and to the State Medical Board's preliminary investigation portal. It was not a thin file. 8 years of military medical service generated a document trail with the particular density of institutional record-keeping that treats every decision as a potential exhibit, and the non-classified portions of Lena's file had that density in full. Training records, deployment rosters, commendation letters, quarterly performance evaluations that used words like exceptional and consistently exceeds operational parameters, and, in one case from a colonel whose name she still respected, the most capable trauma specialist I have commanded in 22 years of service. Field surgical logs, patient outcome records that listed, across 4 deployments, a survival rate for critical trauma cases that would have been remarkable in a Level 1 trauma center and was, in forward operating conditions, genuinely without precedent in her unit's history. And then the gap. Not a gap in the record exactly. It was there. It just changed texture. The operational incident, the formal objection, the reassignment, the discharge request. The portion that was still classified ran like a fault line through the document, visible in the sequential numbering. Page 47 to page 63, redacted, replaced by a single line. Content withheld under operational security review, classification level pending. Dr. Anand read the file in her temporary office, a conference room the administration had provided with the particular reluctant hospitality of an institution that understood it was obligated to cooperate and was not happy about it. She read it with the full attention of someone who had spent 30 years in medical oversight and had seen personnel files that ran from impressive to catastrophic, and could generally tell, by the 3rd page, what category she was in. By the 3rd page of Lena Marsh's file, she knew she was in a category she had not encountered before. She kept reading. Calloway found out about the file through the communications director, who found out through the administrative assistant who processed visitor access requests, who had flagged the federal transfer notification because flagging unusual system activity was part of her job description, and she was very good at her job description. He was in his office when he got the call. He sat at his desk and listened, and when the call ended, he stayed very still for approximately 30 seconds, which was the amount of time it took him to recalibrate from the strategy he had been running for 4 days to the reality that the strategy had assumed a file that did not exist and had encountered a file that very much did. He called Patricia Vane. She answered on the 2nd ring, and he told her what had come through, and there was a silence on her end that had a specific quality, not the silence of someone who was surprised, but the silence of someone who was deciding how much to say about the fact that they had suggested this was a possibility. "How extensive?" she asked. "I don't have the full document. I have the summary the comms director got from the admin log. 8 years, 4 deployments, a field surgical credential." He paused. Commendations. Another silence. "Richard," she said, "I need you to listen to me carefully." "I'm listening." The complaint, as filed, alleged scope of practice violation. The basis for that allegation was the assumption that a nurse without specialized training had performed clinical procedures outside her documented competency. She paused. If the file establishes that she has 8 years of trauma surgical training at an operational level, the civilian license still, "Richard," her voice was flat. "Stop." The scope complaint depended on her being unqualified. She is not unqualified. She is extraordinarily qualified in a way that was not visible in her institutional record. And the complaint I helped you file is now a public document suggesting that a former military trauma surgical specialist with a distinguished service record acted improperly when she saved 6 lives. She stopped. "Do you understand what that looks like?" He was quiet. "Do you understand," she said, more carefully, "what it looks like if this goes to a hearing? If she stands in front of the board with that file and those patient outcomes and that service record, and the opposing document is a complaint filed by the executive director of the hospital she works for." His office was very quiet. Outside his window, the parking structure lights had come on. It got dark early in February, and the building's reflection was visible in the glass, pale and doubled. "What are my options?" he asked. "Withdrawal," she said. "Today, before the inquiry formally schedules a hearing. Frame it as administrative review pending new information. It doesn't close the investigation, that's Anand's call, but it removes your name from the opposing position." "That looks like retreat." "It looks like prudence," she said, "which is better than what it looks like in 6 weeks when the hearing transcript is public record." He sat with it. He did not like it. He was a man who had built a career on the premise that institutional momentum was the most reliable form of power. And withdrawing a complaint 4 days after filing, it was not momentum, it was the opposite of momentum. And he was aware that the people who watched institutional dynamics, the board members, the department heads, the administrative community that was small enough in Harmon County to constitute an actual community, would see it as exactly what it was. But Vane was right. He knew she was right. He had known she was right approximately 2 minutes into the call, and he had spent the intervening time looking for a version of the situation in which she was wrong, and he had not found one. "Withdraw it," he said. "I'll draft the notice tonight." "Patricia." He stopped her before she hung up. "The staffing records that Holt attached." "Yes. Is there exposure there?" The silence this time was longer. "There's a conversation we need to have," she said, "that is separate from the complaint and separate from the inquiry. About the staffing decisions, the budget correspondence, and who signed what over the last 14 months. She paused. "Not tonight, but soon." "How bad?" "I'll tell you when I've read everything." She hung up. He set his phone down. He looked at his desk. At the preliminary complaint file he had printed that morning, at the liability carrier's preliminary assessment, at the communication director's talking points for the internal narrative he had been building. He pulled the complaint file toward him. He looked at the top page. He thought about Lena Marsh in the corridor, the way she had walked past him without looking directly at him, the way she had moved through this building for 4 days since the convoy night, with the same unhurried steadiness she apparently moved through everything with. And he recognized, with the particular clarity of a man who had just made a significant strategic miscalculation and was still in the window of understanding it fully, that he had misread her completely. He had seen a nurse. He had not seen the file. Donna Peach heard about the withdrawal at 7:15 that evening from Patricia Vane's office assistant, who called to confirm the formal notice had been filed with the board inquiry. She was standing at the nurse's station doing end-of-shift reconciliation when her phone rang, and she listened to the information and said thank you and set the phone down and stood there for a moment looking at the patient board. Then she went to find Lena. She found her in the medication room, pulling the next patient's scheduled doses with the methodical attention she applied to everything, reading the labels twice, checking the chart cross-reference, setting each item in its designated position on the tray. "Calloway withdrew the complaint," Donna said. Lena did not stop what she was doing. She checked the next label, set it on the tray. "When?" she asked. Notice filed an hour ago, Vane's office. Lena nodded once. She finished the tray. She picked it up. Donna, she said before she walked out. The inquiry is still open. I know. Anand doesn't close it because Calloway withdrew. She closes it when she decides the clinical record is complete. She looked at her. I want it to stay open. Donna looked at her. Why? Because a closed inquiry means the file stays where it is. An open inquiry means the service record is in the evidentiary record. She held the medication tray. If this closes quietly, in 3 months, it's a story about a scope complaint that got withdrawn. I need it to be a different story. Donna was quiet for a moment. The staffing records, she said, the ones Holt attached. Yes. Those are going to be ugly. Yes, Lena said again. They are. She walked out of the medication room, and Donna stood in the antiseptic quiet and thought about 14 months of budget emails and staffing requests, and the specific series of administrative decisions that had put 3 second-year residents in charge of a trauma department during a mass casualty event. And she thought about the word ugly and decided it was probably too mild. Itek. Holt's formal statement to the inquiry was 12 pages. He had written it himself without Vane's assistance, which was a choice he had made deliberately and which Vane found out about the following morning and called him about in a tone that was not quite alarm and not quite admiration, but contained elements of both. You submitted a 12-page statement without running it through legal, she said. It's factually accurate, he said. That's not the same as legally, Patricia. His voice was pleasant. I'm a surgeon. I document facts and outcomes. That's what I did. The statement documented, in sequential clinical detail, the staffing situation at Cascade Ridge's trauma department over the 14 months preceding the convoy event. It documented his requests, 7 of them, each progressively more urgent, for additional surgical staffing. It documented the administrative responses, or the absence of them. It documented the budget justifications that had been provided for declining each request, which were uniformly financial, and it cross-referenced those justifications with the documented patient volume increase over the same period, which had been 31%. It then documented with the same clinical precision the convoy event, the patient presentations, the interventions, the outcomes, the specific moments at which the understaffing became the operative constraint on patient survival. And it documented Lena Marsh's role not as a scope violation, but as a competency deployment. A person with demonstrably applicable training providing guidance to less experienced clinicians in an emergency created, at least in part, by institutional resource failures. The statement did not accuse Calloway directly of anything. It didn't need to. The chronology did it for him. Dr. Anand read the statement on the morning of day 6. She read it twice. She made notes in the margins of her printed copy. Precise, small annotations in the manner of someone who had developed a shorthand for the specific category of this is going to have institutional consequences. Then she requested a meeting with the hospital board, not Calloway. The board. The distinction was not subtle and was not missed by anyone who heard about it, and in a building this size, everyone heard about it. The board met on day 7. 7 members, a conference room on the 4th floor with a view of the parking structure and the mountains beyond it, and the particular gray-white sky of Montana in February that made everything look like a document being prepared for formal submission. Anand was there. Holt was there. Stroud was there, which several board members had not expected, and which created a brief procedural discussion about his status, which he resolved by presenting credentials and saying nothing further and sitting in the chair he'd chosen with the particular stillness of a person who was used to being in rooms where he was not originally on the agenda. Calloway was not there. He had been informed of the meeting. He was not invited. The board chair, a retired internist named Dr. Garrison Ellery, who was 72 years old and had the particular authority of someone who no longer needed anything from anyone, opened the meeting by reading a 2-sentence summary of the situation and then asking Dr. Anand to present her preliminary findings. Anand presented for 40 minutes. She was thorough. She was specific. She was not emotional, which made the factual content considerably more effective than it would have been with emotion attached to it. She presented the clinical outcomes, She presented the service record. She presented the staffing correspondence. She presented a timeline of the administrative decisions that had led to the understaffing situation. She presented the complaint, its basis, and its withdrawal. She did not present a recommendation. She presented findings. The distinction, in inquiry language, was that findings were facts and recommendations were opinions, and Dr. Judith Anand was very clear on the difference. When she finished, the room was quiet for a moment. Then Dr. Ellery said, "The complaint was filed by the Executive Director of Operations." "Yes," Anand said, "against a staff member who, by the clinical record, was instrumental in preventing multiple patient deaths." "That is one characterization supported by the record," Anand said. "The record also supports other characterizations, depending on which regulatory lens you apply." "And the staffing record?" "Is a separate matter from the inquiry's scope," Anand said. "But it is part of the factual context, and I have included it as such." Ellery looked at the board members on either side of him. He had the manner of a man who had already formed his view and was doing the courtesy of allowing the room to catch up. "I'd like to hear from Dr. Holt," he said. Holt spoke for 11 minutes. He was not 12 pages of precise clinical documentation. He was a man who had spent the last 7 days doing something he was not entirely comfortable with, which was examining his own institutional behavior with the same rigor he applied to other people's. And the discomfort was visible in a way that made him more credible, not less. He talked about the staffing requests. He talked about the outcomes. He talked about Lena Marsh in terms that were clinical and accurate and, at one point, simply honest in a way that had nothing to do with clinical language. "I didn't see her," he said. "She worked on my floor for 2 years and I did not know her name. I want the board to understand that I'm saying that as a data point about the institutional culture of this department, not as an apology that I think changes anything. She was invisible because we made her invisible. The night of the convoy event, she stopped being invisible because she couldn't afford to let people die in order to preserve my comfort." He paused. "That's the record. That's what I want the board to have." The room was quiet after that. Stroud did not speak unless asked. He was asked twice, once about the classification hold and its current status, and once about the federal oversight dimension of having military patients involved. He answered both questions in the flat, precise manner of someone who was providing information and making no argument. The meeting lasted 3 hours. When it ended, Dr. Ellery did not announce a decision. The board did not vote on anything in the meeting. What happened instead was the thing that happens when institutional bodies have received information they cannot unreceive, which is that they adjourned with a particular quality of quiet that was different from the quiet of a meeting that had produced nothing. Holt knew what that quiet meant. He had been in enough hospital board meetings to read the atmosphere the way meteorologists read pressure gradients. Something had shifted. He didn't know the shape of it yet. He found out 2 hours later when his extension rang and Garrison Ellery said, without preamble, "We're opening a full administrative review of the operations division. Staffing decisions, budget allocations, the complaint filing, the scope." A pause. "I'd appreciate it if you'd be available as a clinical resource." "Of course," Holt said. "And Dr. Holt." A brief pause. "Thank you for the documentation." The call ended. Holt sat in his office and looked at the window and thought about 14 months of budget correspondence that he had kept because he was organized and because some part of him had known, in the way you know things you don't say out loud, that they would matter eventually. He had not known it would matter like this. He was glad he had kept them. Lena heard about the administrative review through Donna, who heard through the board secretary, which was the natural pathway of information in this building and always had been. She was doing patient rounds when Donna found her, and she listened and nodded and went back to checking the patient's drainage output, which required her full attention because the numbers had been trending in a direction that was not alarming but bore watching. "That's it?" Donna said. "Just okay?" "The review was going to happen, or it wasn't," Lena said. "It's going to happen." She wrote the output number in the chart. "That's good. Calloway's going to fight it." "He can fight it." She moved to the next patient. "It's documented." Donna followed her down the corridor with the expression of a person who had expected a different register of response and was recalibrating. "Lena," she said, "you should—" She stopped. Started differently. Are you okay? Lena checked the second patient's vitals. She wrote them down. She looked at the patient, a young man, one of the convoy soldiers, sitting up now, a paperback novel open on his lap. And she said to him, "How's the pain level today?" And he said, 6 maybe. "Better." And she made a note and moved the bed adjustment and said, "Tell me if it goes up," and moved on. In the corridor, she said to Donna, "I'm fine." That's not an answer. It's the accurate one. She stopped walking. The review is open. The service record is in the inquiry file. The complaint is withdrawn. She looked at Donna. The officer is still serving. Donna looked at her. The one from the incident, Lena said. The one the classified section covers. He's active. He's been promoted. She said it the way you say the weight of something out loud when you're trying to understand what you're actually carrying. Whatever happens here, the inquiry, the review, the administrative consequences for Calloway, the classified section is still the classified section. The formal objection I filed is still sealed. The soldier who died is still dead. Donna was quiet. "I'm sorry," she said finally. It was not the reflexive kind. She meant it. "I know," Lena said. "I know you are." She moved on down the corridor. On day 9, the board convened a separate session that was not on the public calendar and did not appear in the administrative schedule, and which Calloway found out about at 6:15 in the morning through a source he did not identify when he later described the events of that day to Patricia Vane. The session lasted 90 minutes. When it ended, Garrison Ellery called Calloway's extension. Calloway answered. Ellery told him 3 things. The first was that the administrative review had been expanded to include the operations division's staffing decisions for the previous 24 months, not 14. The second was that the board had voted to engage an independent clinical auditor to review the trauma department's patient outcomes over the same period, with specific attention to cases where staffing constraints may have affected care. The third was that Calloway was placed on administrative leave, effective immediately, pending the outcome of the review. Calloway said, "I want that in writing." "It will be on your desk within the hour," Ellery said. "HR will be in contact about the process." The call ended. Calloway sat in his office, the office with the parking structure view, the office where he had drafted the complaint at 8:42 in the morning 9 days ago with the confident precision of someone who believed the target was small enough and the ammunition was enough. And he sat there for a while looking at his desk, at the documents that covered it, at the specific geometry of a situation that had fully inverted from the one he'd been managing. He had tried to contain a liability. He had created one. He had tried to remove a problem. He had illuminated one in a document trail that was now part of a board-level administrative review, and the illumination was not of Lena Marsh. He called Vane. She answered. He told her. She was quiet for a moment, and then she said the thing he had known she was going to say, which was, "Don't say anything to anyone until we've spoken." "Nothing, Richard. Not to HR, not to the board, not to anyone on staff. Do you understand?" "Yes," he said. "I'll be there in 2 hours." She arrived in 1 hour and 40 minutes, which told him something about her assessment of the urgency. Lena found out about Calloway's administrative leave from Travers, of all people, who heard it from the charge coordinator, who heard it from the board secretary, and who came to find Lena at the nurse's station at 11:20 in the morning with the expression of someone delivering news they were not sure how to read. "He's on leave," Travers said. "As of this morning." Lena was charting. She looked at him. "The review?" she asked. "I think so." He leaned against the counter. He looked younger than he had the night of the convoy, or maybe just less frightened, which had the effect of making him look younger. "Dr. Holt says the independent audit is going back 24 months. I heard." "That's—" He stopped. "Some of those cases are going to look bad, if the staffing was the issue across that period." It probably was. He was quiet for a moment. "Some of those outcomes, we thought they were just—" He stopped again. "We thought that was just how it was, in a small facility, with the volume we have." "I know," she said. "But if the staffing, Travers." She looked at him. You did the work you were given with the resources you had. The audit isn't about your performance. It's about the decisions that determined your resources. She held his gaze. You understand the difference? He thought about it. Yes, I think so. Good. She went back to the chart. He stood there for another moment. Then, Dr. Holt wants to meet with you, this afternoon if you can. Tell him 4 o'clock. Okay. He pushed off the counter, stopped. The patient in Bay 3, the first one, the decompression. He paused. He got moved to general ward this morning. He asked the nurse to find out your schedule. I think he wants to actually talk to you. She looked at the patient board. She found the name, Weaver, James, Ward 4C, and she looked at it for a moment. I'll stop by on my break, she said. He's been asking since day 2. I know. She closed the chart. I'll stop by. Travers nodded and left, and Donna appeared at her elbow from wherever Donna materialized from, and said, He asked for you specifically. On the first night, apparently he could hear your voice when he was going out. He said it's the reason he didn't. Lena looked at the board, at Weaver, James. That's not accurate, she said. The needle decompression is the reason he didn't. He knows that. He still wants to thank you. She picked up the next chart. 4 o'clock, she said. I'll see Holt. After that, I'll go to 4C. Donna made a sound that was not quite agreement and not quite exasperation, but lived somewhere between them. Holt's 4 o'clock meeting was not what she expected. She had expected a debrief, a formal or semi-formal conversation about the inquiry status, the review, Calloway's leave. She had prepared herself for the institutional conversation, for the careful language of people managing a situation in progress. What she found when she walked into his office was Stroud. He was sitting in the chair she usually took. He had his tablet open. He looked up when she walked in, and he had the expression he'd worn in the corridor when he'd told her about the promotion. Not careful, not managed, just direct in a way that Stroud was almost never direct in front of witnesses. She looked at Holt. He was at his desk. He had his hands flat on the desk in the way he did when he was sitting with something uncomfortable. What happened? She said. Stroud answered. The classification review came back. She sat in the other chair. The formal objection, he said. The incident report you filed. The classified elements. He looked at his tablet. The review board cleared the document for limited disclosure within the scope of the ongoing inquiry. He paused. All of it. She sat with that. The incident, she said. The soldier who died. Yes. The officer's decision. Yes. And the response to the formal objection, the dismissal, the reassignment. Yes. His voice had the careful flatness of someone delivering information they know has weight. All of it is now disclosable within the inquiry's scope. She looked at her hands. And the officer's current status, she said. That's part of the disclosure. The office was quiet. Outside, the building's heating system made a low, intermittent sound that she had never noticed before, or had noticed and stopped noticing and was noticing again now. Lena, Stroud said. He almost never used her name. The disclosure goes to Anand's inquiry. What she does with it is her determination. But the officer's name is in the formal objection. His decision is documented. The chain of command response is documented. He paused. The DoD Oversight Office received a copy of the inquiry record this morning as a matter of military patient protocol. They have the disclosure flag. She looked at him. They've already opened a parallel review, he said, independent of this facility and this inquiry of the original incident. The weight of it settled in the room. 4 years. 4 years of careful management, careful distance, careful invisibility. 4 years of the soldier's name carried quietly in the back of her mind like an obligation she had accepted without resolution, because resolution had seemed impossible, and she had learned to function without it. The parallel review was not resolution. It was a door. She looked at Holt. He was looking at her with the expression of a man who understood he was sitting in a room where something larger than his trauma department was in motion, and who had not flinched from it. You need to know, he said, before you decide anything, that this review, the DoD review, is going to be visible, Not publicly, not immediately, but within military and federal channels. The officer's name is going to be associated with a formal re-examination of a classified incident. I know what that means, she said. His position. I know what it means, Marcus. He was quiet. She looked at the window, at the parking structure, at the mountains beyond it, just visible in the last of the afternoon light, dark shapes against a sky that was doing its slow February transition from gray to dark, the color changing the way things change when the day is ending and what comes next hasn't announced itself yet. What do you need from me? She asked Stroud. A formal statement confirming the incident details. On record, for the DoD review. When? Tomorrow morning, if you're willing. She thought about the soldier, about his name, which was Torres, which she had known for 4 years, and had never said aloud to anyone in this building, and had not forgotten for a single day of those 4 years. I'm willing, she said. Stroud nodded. He closed his tablet. There's one more thing, he said. She looked at him. The officer has been informed that the classification review was completed. He held her gaze. His legal counsel contacted the DoD Oversight Office this afternoon. A pause. He's filing a counterstatement, preemptively. She understood what that meant. It meant the officer, the man who had ordered Torres loaded into a transport vehicle when she had told him he would not survive it, the man who had dismissed her formal objection, the man who had been promoted twice since the day she filed that report, was not going to let the review proceed without a fight. It meant the disclosure, the review, the formal statement she would give tomorrow morning, all of it was now contested. It meant it was not over. It had, in fact, in the specific sense that mattered, just begun. She sat in the chair in Holt's office with the mountains going dark outside the window, and she felt very precisely the specific quality of a 4-year waiting period ending and something else starting, and the something else did not have a clear shape yet, but it had her full attention. Okay, she said. Her voice was steady. Her hands were steady. The rest, she could not guarantee. She gave the formal statement the next morning at 9 a.m. It took 2 hours and 40 minutes, which was longer than Stroud had estimated and shorter than she had feared. She sat across from a DoD oversight officer named Reyes, compact, 40s. The kind of careful listener who took notes by hand instead of typing, because handwriting was slower and slower meant you heard more. And she told him about Torres. She told him everything, not the outline she had given Holt, not the carefully weighted version she had carried for 4 years. Everything. The field conditions, the assessment, the specific clinical reasoning she had presented to the medical officer when she told him Torres was not transportable, the officer's response, the loading of the vehicle, the 12 minutes, the outcome that she had predicted with an accuracy that had never given her any satisfaction whatsoever, because accuracy without consequence was just documentation of a thing that should not have happened. She told him about the formal objection, about the 37 pages she had written, the clinical evidence she had assembled, the chain of command she had filed it through, about the response, which had come in writing 14 days later and used words like operationally unfounded and superseded by command authority, and which she had read 3 times in a supply tent in the dark, and then folded and put away because she had understood, reading it, that the institution had made its choice and she was not going to change it by filing another document. She told him about the discharge, about the decision to leave, which was not a breakdown, not a collapse, not the thing people assumed when they heard about someone leaving a military career after an operational failure. It was a choice, a cold-eyed, fully conscious choice made by someone who had looked at the institution she served and concluded that she could no longer trust it with her judgment, and that operating within an institution you did not trust was a form of negligence she was not willing to commit. Reyes listened. He wrote. He asked 3 clarifying questions, all specific, all clinical, none of them the kind designed to undermine or redirect. When she finished, he looked at his notes for a moment. The officer's counterstatement, he said, characterizes the transport decision as consistent with protocol for the patient's presentation at the time of assessment. The protocol exists for stabilized patients, she said. Torres was not stabilized. That distinction is in the original objection with the clinical parameters. He disputes your assessment of the patient's stability. He was not the one with hands on the patient. She held his gaze. I was. Reyes wrote one more line. He closed his notebook. We'll be in contact, he said. She drove back to Cascade Ridge and changed into her badge and went to work. Because work was what she had, and she was not going to spend the hours of waiting in stillness when there were patients who needed their vitals checked and residents who needed their questions answered, and a trauma department that was, quietly and without announcement, beginning to function differently than it had 9 days ago. The weeks that followed were not clean. They were not the montage version of institutional accountability, where the right outcome arrives efficiently and the people responsible face their consequences in a satisfying sequence. Real accountability moves the way glaciers move, slow, heavy, and with a grinding quality that is not dramatic, but is, ultimately, more thorough than anything fast. The independent clinical audit of Cascade Ridge's trauma department took 6 weeks. The auditor, a thin, relentless woman named Dr. Priscilla Osei, who had conducted 11 similar audits across 3 states, and who had the specific energy of someone who found institutional failure genuinely offensive rather than merely professionally interesting, went through 24 months of patient records with the attention of a person who understood that documentation gaps were not accidental. She found 14 cases across the review period in which staffing constraints had materially affected care quality. 3 of those cases had outcomes that she categorized as potentially preventable adverse events. Not malpractice, not negligence on the part of the clinical staff, but outcomes that a fully staffed department might have avoided. She documented all of it. The audit report went to the board. The board held a formal session. Callaway, still on administrative leave, was represented by Patricia Vane, who had spent the intervening weeks doing the work of an attorney who knows the facts are not on her client's side and is focused entirely on managing the consequences rather than contesting them. The board voted. The outcome was not surprising, but the specificity of it mattered. Callaway was removed from his position, not resigned, not mutually agreed upon separation, removed with the particular institutional language that distinguished between a person who leaves and a person who is asked to leave and cannot decline. The removal was tied explicitly to the audit findings, to the staffing decisions, to the pattern of budget denials across the review period, and to the complaint filing, which the board characterized in its formal minutes as an administrative action inconsistent with the clinical evidence available at the time of filing. That last phrase was Ellery's language. Lena recognized it when Donna read her the relevant section over the phone while she was in the break room eating a sandwich she had been trying to finish for 40 minutes. Inconsistent with the clinical evidence available at the time of filing. It was precise. It was restrained. It was, by the standards of institutional language, about as direct a rebuke as boards ever put in writing, which meant it was more damning than it sounded to anyone who did not know how to read it, and perfectly clear to anyone who did. "That's it?" Donna said. "He gets removed, and that's the language they use?" "That's the language they use in the minutes," Lena said. "The employment consequences are in the HR documentation. Those are different, which you won't be able to see." "No, but Vane will." She took a bite of the sandwich. "And the audit report is going to the State Health Commissioner's office. Callaway's name is attached to 14 cases." Donna was quiet for a moment. "Is that enough?" Lena thought about it. "It's public record for the rest of his career." It was not a perfect answer. She knew that. The 14 cases were documented, the staffing failures were documented, the removal was documented, and Callaway would spend a significant and uncomfortable portion of his professional future managing the fact that those documents existed. But the 3 adverse event cases would never be fully resolved. The patients in them had received imperfect care, and nothing that happened in a conference room on the 4th floor of this building would change that. She knew that. She held it. She did not put it down. The DOD review took longer. 8 weeks from her formal statement to Reyes, during which she received 3 calls, one from Reyes asking a follow-up question about the transport timeline, one from a DOD attorney whose role she gathered was to assess the legal exposure of the original dismissal, and one from Stroud, who called on a Tuesday evening and said simply, "It's moving," and did not elaborate because he was not someone who elaborated unnecessarily. She worked. She managed her patients. She watched Travers and Ferris develop, visibly, measurably, in the way that good clinicians develop when they have been in proximity to someone who does not hide the work. And she found that watching this was the part of her days she liked best, which told her something she had been reluctant to look at directly. She had not stopped being a teacher just because the places she had taught were not classrooms. She had not stopped being a surgeon just because she was not holding a scalpel. She had just been hiding both behind a job title that let her do neither officially, and the protection it had offered was real, and the cost of it was something she was only now adding up fully. Holt brought it up on a Wednesday afternoon in the slow hour between shifts when the department had a temporary lull and they were both standing at the nurses' station looking at the patient board. "The residency program," he said. "Not building to it, just saying it." "What about it?" "I've been thinking about a formal trauma surgery preceptorship, something structured, for the second and third years." He did not look at her. He was looking at the board. It would need to be run by someone with the right background. She looked at the board. "My license status is still under inquiry," she said. "The preliminary review was favorable. Anand's interim finding cleared the clinical record. The full determination is a formality at this point." He paused. "I have the board's support for a preceptorship position. It would be a new role, not an attending, not a nursing role, something that recognizes what you actually are without requiring us to pretend the existing categories cover it." "What does it pay?" she said. He almost smiled. "More than you're making." She looked at the board. She thought about Torres, about the formal statement she'd given, about the review that was still moving through the DoD's slow machinery, about the officer whose name she had written on 37 pages 8 years ago, and whose counterstatement was in a federal file alongside her own words. She thought about the distance she had kept from all of it for 4 years, and about what it had cost her to keep it, and about whether that cost had been worth what it bought. "Let me think about it," she said. "Take the time you need." He picked up a chart. "The offer doesn't expire." She went to check on her patients. The DoD determination came on a Friday. Not a call this time. A formal written notification, delivered through the secure channel Stroud had given her access to, addressed to her by name and rank, the rank she had left behind, which was captain at the time of discharge and which the document used anyway, the way military paperwork reaches backward through time. She read it standing in her kitchen at 6:15 in the morning with coffee she hadn't touched yet. The review board had determined that the original dismissal of her formal objection had been procedurally improper, that the clinical evidence she had provided met the threshold for mandatory command review, which had not occurred, that the reassignment following the objection filing constituted retaliatory administrative action inconsistent with DoD medical personnel policy. The officer, his name was Colonel Dennis Farrelly, and she had not said his name aloud in 4 years and said it now, quietly, in her kitchen, just to hear what it sounded like without the weight of sealed classification attached to it, had his counterstatement rejected. The review found his account of Torres's clinical presentation inconsistent with the field documentation and with Lena's contemporaneous assessment. Farrelly was facing a formal conduct review. He had been placed on administrative hold pending its outcome. His most recent promotion was under review by the Personnel Board. The last paragraph of the notification was the one she read 3 times. It stated that the formal objection she had filed 8 years ago was being entered into the permanent operational record as a validated clinical finding, that Torres's death was being reclassified from operational outcome to preventable adverse event under command authority, that a notation would be placed in the operational record acknowledging that the on-site medical assessment performed by Captain Lena Marsh had been clinically accurate. She set the notification down on the kitchen counter. She stood there for a moment. Outside, the sky was doing the thing it did in Montana in late March, which was beginning tentatively and without any real commitment to suggest that winter might eventually end. The light was the particular pale color of early spring in high country, not warm yet, not promising warmth, just suggesting that warmth was theoretically possible, which after February was enough. She picked up the coffee. She drank it. Torres had a daughter. She knew this because he had told her, in the field, before she had known how things were going to go. A little girl named Mia, who was 18 months old and had just learned to pull herself upright on the furniture. She did not know what had happened to them. She had not let herself know, because knowing was a form of contact with the thing she had walled off, and the wall had been necessary for functioning. The wall was down now. She thought about Mia, who would be 9 years old, and about what it meant that a document in a federal file now said her father's death was preventable, and about whether that was a thing that helped or simply a thing that was true. And truth was not the same as help. Not always. Not automatically. She thought, it is something. A name on a record. A finding that says he should have lived. A notation that says the person who tried to save him and was ignored was right. It was not enough. Nothing would be enough. But it was something, and she had learned, in the specific hard way that people learn things they would rather not have to, that something was not nothing and the distinction mattered. She put the cup down. She got dressed. She went to work. The state medical board's final determination came the following week. Dr. Anand delivered it in a written finding that was, by the standards of regulatory documents, almost brisk in its directness. The scope of practice complaint was dismissed with prejudice, meaning it could not be refiled on the same grounds. The clinical record from the convoy event was cleared. The interventions attributed to Lena Marsh's guidance were found to fall within emergency exception provisions applicable to credentialed military medical personnel in mass casualty situations, a provision that existed specifically because the DoD and the state medical boards had, at some point in the previous decade, collectively acknowledged that combat trauma training produced capabilities that did not map cleanly onto civilian licensing categories. The finding also included a recommendation, not binding, directed to the hospital board, that Cascade Ridge Medical Center develop a formal policy for credentialing personnel with military surgical training in civilian institutional roles. It was, in regulatory terms, a sentence in a document. In practical terms, it was the door Holt had been waiting for. He called Lena at 7 in the evening, with the finding still open on his screen. "The preceptorship," he said. "I want to move on it." "I know." "That's not an answer." "Yes," she said. "That's an answer." A pause on his end. She could hear him adjusting in his chair. "Good," he said. "Marcus." She stopped him before he went into the logistics, which she could tell he was about to do because she had worked beside him long enough to know that logistics were what he did with emotion he didn't quite know what to do with otherwise. "Thank you for the documentation, for the staffing records, for all of it." He was quiet for a moment. "You would have survived without it," he said. "Probably. But not the same way." Another pause. "I spent 2 years not seeing you," he said. "I don't plan to make a habit of it." She believed him. She said goodnight and hung up and stood in her living room for a moment, looking at nothing in particular, holding the specific and unfamiliar feeling of a thing she had braced against for a long time not happening. Mom. The ceremony the hospital held was not her idea and was not something she would have asked for, and she said so clearly to Donna and to Holt and to Garrison Ellery when he called to inform her of it, and all three of them said, in different words, that it was happening regardless. It was not a large event. A conference room, not an auditorium. The 6 convoy patients who were well enough to attend, 4 in person, 2 by video call on a laptop propped on a chair, which was unglamorous and exactly right. The residents, the nursing staff, the board. Some of the paramedics from the night of the convoy. Stroud, in the back of the room, who had found somewhere to be in Harmon County for the week in a way that she suspected was not coincidental. Ellery spoke briefly. Holt spoke briefly. Dr. Anand, who had driven up from the regional board office, said 3 sentences, and they were the right 3 sentences. Specific, accurate, without inflation. Then Dario Fusco spoke. He was standing without a crutch, which he had been working toward for 2 weeks and had achieved 4 days ago. And he stood at the front of the room with the particular posture of a man who has been through something that rearranged his understanding of what mattered and was still in the process of finishing the rearrangement. He had notes on an index card that he looked at once and then didn't look at again. "I've been trying to figure out what to say since I woke up in the ICU," he said. "I've been in the Army long enough to know the difference between people who do the job and people who do the job when it costs them something. That night, he stopped. Started again. That night cost her something. I don't know all of what it cost, but I know what it looked like from the other end of it, and I know she didn't have to stay in that room, and she stayed, and I'm here, and that's what I've got. He sat down. The room was quiet in the way rooms are quiet, when something real has been said and there isn't anything adequate to follow it. Lena stood at the front of the room. She had prepared something to say, and she did not say it, because the thing she had prepared was careful and accurate, and what she actually felt was neither careful nor easily articulated. She looked at the room. At Travers, who had done a Reboe placement under her voice in a bay where the pressure was 48 and the time was running. At Ferris, who had put a needle into the right intercostal space at the right angle at the right moment because someone had told her she could. At Gloria Tesh, who had been passing information between people for 9 days with the quiet reliability of infrastructure. At Donna, who had known for 2 years that something about Lena Marsh didn't add up and had chosen to let it not add up rather than push, which was its own form of grace. At the laptop propped on the chair, where 2 men were watching from a hospital room in another city, small and pixelated and absolutely present. "I'm not good at this," she said. "Talking about it." A few people made a sound that was not quite laughter but was something adjacent to it. "What I know how to do is the work," she said. "I've known how to do the work for a long time, and for a long time I thought the work was enough. That doing it quietly and correctly and not asking for anything in return was a kind of integrity." She stopped. "I think that's partly true and mostly wrong. Partly true because the work matters regardless of who sees it. Mostly wrong because the people around you, the people you're teaching whether you mean to or not, the people whose hands you're steadying, the residents who are going to be in those bays long after you, they need to know that this is possible, that someone has done it, that the standard exists." She looked at Travers. "You did a Reboe placement correctly under conditions that would have folded most people. That was your hands. That was your training. I just told you what you already knew." She looked at Ferris. "Same." She looked at the room. "The thing about being invisible for a long time," she said, "is that you start to think invisible is the only safe way to exist. And then something happens that makes you visible, and you realize you were wrong about what safety was." She paused. "I was keeping myself safe from things that had already happened. The people in the trauma bays on the night of the convoy needed me to show up, not to protect myself. I should have figured that out sooner." It was not a clean ending to what she was saying. It was not a bow on anything. It was the honest version, which meant it was incomplete and true, and she had decided that incomplete and true was what she had to offer, and it was enough. She sat down. Holt to her right did not say anything. He did not put his hand on her shoulder or nod at her in a way that meant anything performative. He just sat beside her in the ordinary way of people who are in the same room together, which was, in its way, the right thing. The preceptorship started 3 weeks later. There was paperwork. There was always paperwork, and this paperwork was more complex than most because it required creating a role that did not previously exist in the institution's job architecture, which required HR conversations and board approval and a credentialing review and a salary negotiation that Lena conducted with the same flat, accurate efficiency she applied to everything, and which resulted in a number that Donna, upon hearing it, said was still probably not enough. "It's enough," Lena said. "It's not what an attending makes." "I'm not an attending. You should—" "Donna." She looked at her. "It's enough." The first session was a Thursday afternoon, 6 residents in the trauma bay with a simulated mass casualty scenario that Lena had designed herself over 2 evenings, working at her kitchen table with a cold cup of coffee and the specific pleasure of a person doing something they are good at without having to pretend they aren't good at it. She ran them hard, not cruelly, not punitively. She ran them the way she had been run, in conditions that were demanding enough to expose the gaps and clear enough to allow correction, with the specific patience of a teacher who understood that confusion was not failure, but a location, a specific mappable point from which forward motion was possible. She stopped them at the decision points. She asked questions. She let them be wrong, and then showed them exactly why they were wrong and exactly how to be right, not theoretically, but with her hands on the mannequin, with the demonstration immediate and correctable. By the 3rd hour, they had stopped looking uncertain. They had started looking focused. There was a difference. She had always been able to see it. At the end of the session, she stood at the front of the bay and looked at them and said, "You all have gaps. Specific, identifiable, correctable gaps. I know what they are. We're going to work on them." She paused. "You're going to be better than you think you are. The work gets that out of you if you let it." Nobody said anything clever or skeptical. They looked at her the way people look when they have just understood something they will carry forward. She turned off the lights in the bay and walked down the corridor toward the nurses' station, past the room where Dario Fusco had recovered, past the supply corridor where she had stood 6 weeks ago holding a phone with 3 letters on the screen, past the family consultation room where Stroud had told her the options, and she had chosen none of them. She stopped at the window at the end of the east corridor. Outside it was April now, and the mountains were still snow-capped, but the parking structure asphalt was dry, and the birch trees at the edge of the building had started the early tentative stages of greening, small and provisional, the kind of green that was more a suggestion than a commitment, but was there, visibly, undeniably there. She had a patient to see in 4C. A new admission, elderly woman with a hip fracture, surgery in the morning, anxious about it in the particular way of people who had lived long enough to know that hospitals contained real risks and not just hypothetical ones. She would go see her, she would sit with her for a little while, she would answer the questions that had actual answers and be honest about the ones that didn't. She was good at that. She had always been good at that, in every uniform she had ever worn and in the absence of any uniform at all, in the places that asked everything of her, and in the quiet building in northern Montana where she had come to hide and stayed to work, and finally, without planning it and without particularly wanting the cost of it, had stopped hiding. She had a soldier's name on a federal record now. Acknowledged, documented. Torres Luis Armando, gone 12 minutes after a transport she could not stop, finally, listed as preventable. It did not bring him back. Nothing would bring him back. But it meant the record said what was true, and the record would outlast every person in this corridor and every decision that had ever been made to keep it quiet, and there was a 9-year-old girl somewhere who might one day know that the person who tried to save her father had been right and had said so, and had not stopped saying so until someone wrote it down. That was not nothing. She put her hand on the window frame for a moment, not for support, just contact, the ordinary human habit of touching the solid thing, and then she let go and walked toward the elevator. She had work to do. She had always had work to do. The difference now was that she walked toward it with her own name on her badge, and her own history in her file, and her own face turned toward whatever was coming, and she did not check over her shoulder, and she did not slow down. Some people spend their whole lives waiting to become who they already are. Lena Marsh had spent 4 years in careful hiding and one catastrophic winter night being found. And what she had found on the other side of being found was not the recognition she had avoided or the exposure she had feared, but simply herself, present, accounted for, known. It was not a small thing. It was the only thing. She pressed the elevator button. The doors opened. She stepped in, and the doors closed behind her, and she rode up to the 4th floor, where a woman with a broken hip was waiting and afraid. And she walked down the hall and knocked on the door and went in and began.